Good morning and good afternoon to colleagues who are able to join us today. Many thanks for joining us, of course, for this IASC briefing on the integration of mental health and psychosocial support in the COVID-19 response. My name is Mervet Shilbeya, and I am the head of the IASC Secretariat, the Interagency Standing Committee Secretariat. And I'm very honored, of course, to be hosting today's webinar on this very important and very critical issue. This is actually the second briefing that we're holding on the issue of mental health and psychosocial support in humanitarian action, and that is for a number of reasons. First and foremost, of course, it is because it is an issue of importance and it is topical, as well as also recognition of the need to raise further awareness about the silent pandemic. And this is also how we refer to it or labeled it in the first briefing that we held. And even more so, given how topical and critical the issue is in light of the COVID-19 pandemic and the exacerbated or compounded effect that the crisis is having and is likely to have on the mental health and psychosocial situation and state of the most vulnerable populations around the world. We do have a great panel today, and I'm very, very pleased to be joined today by both Dr. Fahmi Henna as well as Ms. Sarah Harrison, who are the co-chairs of the IASC Mental Health and Psychosocial Support Reference Group. Dr. Fahmi Henna is a technical officer with the World Health Organization's Department of Mental Health and Substance Use, and he is a psychiatrist by training and has more than 15 years of experience in mental health services and its development in low and middle income settings. We're also joined by Ms. Sarah Harrison, who's the second co-chair of the IASC Reference Group on Mental Health and Psychosocial Support in Humanitarian Action, and she is a technical advisor on mental health and psychosocial support for IFRC. I'm really pleased and very, very happy to be joined today with two colleagues from the field who are co-chairing level mental health social support technical working groups in both Afghanistan and Nigeria. Ms. Nadia Jabarkhil with Action Against Hunger has over 13 years of experience in mental health and psychosocial support in Afghanistan and has served as chair of the MHPSS Working Group in Kabul since 2019. Ms. Deborah Magdalena with IOM is a clinical psychologist from Indonesia with more than 10 years of experience in professional psychology. She started her humanitarian work in MHPSS with IOM in Indonesia and is currently the coordinator of the MHPSS Working Group in Northeast Nigeria, based in Maiduguri since 2017. I just want to check perhaps just with Christina, just to confirm that our four panelists are indeed online and that they can hear me loud and clear.
Perhaps yes, it may be great if they can all of the panelists just give a quick hello to make sure that we hear you?
Brilliant. Dr. Fahmi, can you hear us?
Hi, Mervet. Hi, Christina. Thank you. Loud and clear.
Brilliant. And Sarah?
Yes, I can hear you. Thank you.
Fantastic. And Deborah?
Yes, I can hear you clearly. Thank you.
Wonderful. And last but not least, Nadia. Nadia, can you hear me? Okay, we'll come back to Nadia in a minute. There might be some technical problems. We'll double check again with Nadia in a few minutes. So, but before I turn to the panelists, and I know that we have quite a rich topic to discuss in an hour. We're hoping actually that we can go a little bit over, and I hope that some of the colleagues that are able to join us today are able to stay with us until 1:15. We'll make sure for future briefings that we actually schedule sufficient time to do justice to the issues and the topics that we are covering here. But before I do turn to the panelists, I'd like to just say a few quick words just to set the scene. Now, we're all aware of the multifaceted impact of the COVID-19 pandemic, and we're starting to witness such impact on the ground. And this is, of course, not only in terms of the direct health implications as a result of COVID-19, but also the socioeconomic implications, the rise, what we're hearing in terms of the rise in protection concerns, gender-based violence, stigmatization, among others, but also how the collapse in the provision of health services in many of the humanitarian contexts is having a ripple effect on other key health concerns. And we've heard from UNICEF around with 80 million children under the age of 1 year not having received immunization in over 60 countries, increased risks of malaria, drop in neonatal care, amongst others. However, for today, of course, the focus is really on the facet of the mental health and psychosocial impact of the COVID-19 pandemic on the millions of the most vulnerable people around the world that we're all here to serve. We have seen a glimpse of this, and we've witnessed some of this impact in some of the most developed nations in the world. We've seen the impact of the lockdown measures, the movement restrictions, the rise in unemployment, amongst others, in these countries, including how it has contributed to the increased incidence of depression, stress, domestic violence, amongst other critical and concerning issues. Now we have to, of course, imagine the situation of the most vulnerable around the world in the context that we are operating in the humanitarian complex context that we're operating in, with the vulnerable already facing serious mental health and psychosocial concerns, and how the pandemic is compounding and exacerbating these mental health and psychosocial issues. So this briefing is definitely timely, given forecasts that the peak of the crisis is expected to rise in the next few months in many of the humanitarian contexts that we operate in. It's an opportunity to hear about and speak to the practical guidance and the capacities that are available to support colleagues in the field on this issue. And it is clear also, and I hope it's becoming more clear also, given of course, the time and the attention we're giving to the issue today, it is a priority for the Secretary General. It is a priority for the Interagency Standing Committee principals, and there is tangible work being done in the space, including with the Global Humanitarian Response Plan, clearly identifying MHPSS as an essential basic need for all vulnerable groups, the accelerated production and endorsement of MHPSS guidance adapted to the COVID response, amongst many other things, which I'm super excited to hear from Dr. Fahmy and Sarah about in the next few minutes. So maybe just against this backdrop, let me turn first to you, Dr. Fahmy, just perhaps to give us in a few minutes just an overview to set the scenes as to why mental health and psychosocial support is critical in humanitarian action, and how have MHPSS concerns been compounded or exacerbated as a result of the COVID-19 crisis. So maybe with that, over to you, Dr. Fahmy, with the first intervention.
Thank you very much. Thank you for the introduction, and thank you for the great opportunity to put MHPSS even more on the agenda. A key reason why MHPSS is and should be a priority in COVID-19 response is that the scale of stressors and their diversity and their nature in many countries due to COVID-19 is unprecedented. But we need to remember that a lot of what we see related to mental health and psychosocial impact of COVID-19 come because there was very limited investment in mental health and psychosocial support in most countries, especially in humanitarian settings before COVID-19. Let's talk, for example, about mental health conditions in conflict settings before COVID-19. The statistics we have in the World Health Organization is that 1 in 5 people in any humanitarian settings, conflict affected, would have a mental health condition. 1 in 5. 1 in 5. If we apply these projections to places such as Yemen, this means Yemen alone have more than 7.5 million people with mental health condition. This is in every emergency, the disaster hidden within the emergency. In a place like South Sudan, serving 12 million people, there are 4 mental health professionals only. This means even before COVID, before service disruption, before the many limitations happening to the service, including the economic burden, for example, for someone to travel, in South Sudan, if somebody having a severe mental health condition and staying in Malakal and need to travel to Juba, they need to travel 2,000 kilometers in a more than 24-hour journey every 2 weeks to reach the only centralized available mental health services in Juba. There are people in every emergency, in every country affected by COVID-19 with pre-existing mental health conditions. There are people where the stressors related to COVID-19 can exacerbate condition. There are people where the stressors related to COVID-19 can have new conditions related. There are many stressors related to COVID-19 that can affect mental health and psychosocial well-being. For example, everyone knows that fear, worry, and stress about one's own health and about one's own family health is widespread everywhere, and about also people economical situation, people sustaining their jobs. And we know that adversity is an important risk factor for having a mental health condition. There are many vulnerable groups in this emergency. One of them, for example, is older adults who are worried about their own health, who suffer more also from physical distancing, which can lead to social isolation. So there are many older adults who are not able to communicate with their social support. Many of them have bereavement because of loss of loved ones. Other vulnerable groups include health workers who face stigma, more than usual working hours, and again, worry about their own health and about their own family's health. So wide range of stressors, but the key message is that really the lack of investment in this area of work before the emergency had led to the disaster we have now with mental health and psychosocial situation and the massive needs. The reports we have from countries is that it really depends on the situation and restrictions in each country where the service utilization, how the service utilization looks like. In a place like Jordan, for example, UNHCR partner reported more than 50% increase on access to mental health and psychosocial support service. The same in northwest of Syria. But in places, for example, such as in Greece, specialized mental health services have shown half of the cases that they receive this couple of months compared to the same couple of months last year. Thank you, Mervyn.
Thank you, Fahmi, again for this very brief but very much enlightening overview, and for really laying out a clear picture of the serious concerns that we're facing on the ground prior to the COVID, and how it's actually been compounded and exacerbated as a result of the COVID-19 response. Again, some alarming figures that you have reiterated around, again, 1 in 5 people in conflict settings suffering from mental health and psychosocial support. Only in Yemen, 7.5 million people that are suffering from mental health and psychosocial concerns. In South Sudan, with over 100 million people in need of assistance, with only 4 mental health clinics, all worrying figures. And again, it points to the serious concern that the problem is a deep-rooted problem, a structural problem that has existed prior to the COVID, and also, again, the critical points that you've highlighted around specific vulnerable groups, from the elders to humanitarian workers to other vulnerable groups that are that their mental health is absolutely being strained and being exacerbated as a result of the current situation that we are experiencing. So maybe just with that, and it's turning to you again, Fahmi, as well as Sarah, it would be great to also get a visual from you and a picture of what are we doing at the global, regional, and the field level to address these serious concerns that you've laid out, Fahmi, and what are the tools that are available to support the field and the response to prioritize and address mental health and psychosocial support issues. So perhaps over to you first. Is it Sarah or Fahmi?
Yeah, thank you, Mervyn. I will start. Christina, thank you. Christina, could you please bring up the slides? Thank you. Yep, so I will start off on this slide and then I will pass over to Fahmi to continue. So as you can see on the left-hand side of the slide, it's the logo for the Mental Health and Psychosocial Support and Emergency Settings Group. The group has been active since 2007 and it was created as an entity within the IASC to promote mental health and psychosocial support work at country level in emergency context based upon the guidelines that were released, and also to improve quality of programming, but also the coordination of programming at country level, as well as doing some policy advocacy work and the tools development work. And with this particular emergency, we were actually meeting virtually at a global level with the technical leads of international agencies, UN agencies, but also international NGOs and national NGOs as well, back at the end of January, when we first noticed that there was this outbreak, the virus outbreak happening in China and in other countries in Asia. So we had quickly decided to have these global level calls that were initially every couple of weeks, and then we had them weekly for a long period of time, for about 3 months, and now we've gone back up to fortnightly calls. And those calls are really the opportunity for the technical advisors within the respective agencies to talk through issues and problems that they are facing, to raise up the concerns from their staff at country level, and also for us to jointly work together in a kind of a collaborative partnership way on the development of tools and of the guidance that we've released, and we will go through afterwards. In addition to these global level calls, perhaps more importantly, we've also been having monthly calls with what we call MHPSS Technical Working Groups that exist in humanitarian context. And by humanitarian context, it covers migration context, such as in Greece that Fahmi mentioned, but also refugee-based settings as well. And also now that's been expanded to include countries impacted by the COVID-19 pandemic. And these monthly calls are with the agency staff who are responsible for convening these interagency groups at country level. So they're technical calls and they're very much about problem solving and kind of action oriented to help them be able to do their job. So for example, how do you do an assessment? What assessment questions are you using? How are you developing indicators for your country level HRPs, for example? But also broader issues like how are your staff? How are your self-care? How is your well-being? What are agencies doing in terms of supporting their staff or their essential workers as well? And then in addition to these more coordination calls and technical calls, we also, our function is also to support the role of the global level clusters in the ongoing humanitarian emergencies. They've not stopped just because there's now a virus pandemic, but also to help them adapt their existing guidance to also include the COVID-19 context. So for example, that means working with the GBV AOR to ensure that we can continue psychological services and support to survivors of sexual violence in conflict, for example, as well as being able to increase for people affected by interpersonal violence that we've seen a massive increase of as well. That's just an example, but we also do a lot of work with the health cluster, the protection cluster more broadly, education and nutrition, and camp coordination and camp management. And I'll just hand over to Fahmi now. Thank you.
Sarah, thank you. Colleagues, back in 5th December, before COVID-19 outbreak, the IASC principals had a very important and a milestone meeting for mental health and psychosocial support. On 5th of December in 2019, the IASC principals agreed to treat MHPSS as a cross-cutting area. And then we had COVID, and there was a need to develop the global humanitarian response plan for COVID. And we see how timely mental health and psychosocial support and the application of this IASC principles recommendation was applied in the GHRP, where MHPSS was identified as cross-cutting in all sectors, from health to protection to camp management and coordination to education to nutrition, among others as well. We see many agencies have included MHPSS activities, and we see for the first time also in an HRP and MHPSS indicator to monitor country level MHPSS technical working group. I think that was great recommendation, and the application was great in COVID-19, and the IASC Reference Group played a key role together with the IASC Secretariat, together with OCHA colleague, to make sure that this happened. We see also an important policy document came this year in May. The UN Secretary General has released a policy brief on COVID-19 and mental health. In this policy brief, the UN Secretary General has spoke about the role of the MHPSS Reference Group and the importance of MHPSS in humanitarian settings, and call on all governments and call on all UN agencies and international actors to make mental health and psychosocial support an integral component of every and each humanitarian response plan and every and each COVID-19 response plan in every country. Next, please. As Sarah mentioned, we started meeting very early in this response on weekly basis in February as focal points for global mental health and psychosocial actors. The 58 member organizations of the IASC were meeting, and we received in the first call that we had at that time, the outbreak was only limited in one country. We received a request from the IASC Reference Group agencies to develop a set of recommended activities, and to develop this set of recommended activities for what agencies would do on mental health and psychosocial support. At that time, it was as part of preparedness. We looked back into what agencies has been doing for mental health and psychosocial support in Ebola. We looked back into the literature reviews that the IASC Reference Group conducted more than 10 years ago during the H1N1 outbreak, and during also many responders to the Zika outbreak. And we looked into learned lessons from the response in China, and we came with a set of recommended activities. Upon its release in February, what we have developed, keeping in mind humanitarian situation and thinking of countries such as South Sudan and such as Bangladesh and Syria, was found relevant, useful, used, adapted, and endorsed by Italy, by the Netherlands, in Hungarian and in Polish, and available on IASC website in this language. So this document was quite influential in the MHPSS response globally, not only in humanitarian settings, but in many high-income countries as well. And then I come to my hero is you. We wanted to develop a public advice targeting children as a vulnerable group from 6 to 11, and we started working on this in March by taking a human-centered approach, asking children themselves. We disseminated a survey in 3 days. We got response from more than 1,800 families from 100 countries who told us how children are coping with stressors and worries related to COVID-19 and what concerns them the most about the changes in their life. We had an excellent story writer who developed the story, which we tested in a number of humanitarian settings. We tested in around 15 humanitarian settings. And My Hero Is You was released on 8th of April. It was released. Now it's a little less than 3 months, and the book was translated. All the translation was requests coming from governments, from UN agencies, international NGOs, academia, and volunteers. Now we have it online on the IASC website in 110 languages. In addition to 110 languages, we have it in more than 35 adaptations, including for children with disabilities, such as in a Braille version and a version with sign language. It was clearly shown that all these countries that take this children book and translated and adapted it, that they prioritize the mental health and psychosocial well-being as equally as physical well-being. The book is now considered one of the most translated books ever by Wikipedia, and still the requests for more translations are ongoing. Over to you, Sarah.
Thank you, Fahmi. I will just talk about the last 2 products on this slide. The next one, the operational considerations for multi-sectoral mental health and psychosocial support programs during the COVID-19 pandemic. This document's actually just been cleared yesterday, actually, for wider release and dissemination, and translations are ongoing now as well into other languages. This document actually was never, when we first thought about this document, we didn't actually have the document or the tool in mind. It was done the idea came from the fact that we were having these quite technical calls with country level staff who were really having to think through, how am I going to adapt my humanitarian services, my mental health services, my psychosocial support services to this new context? What standard operating procedures do I need to change? What new ones do we need to develop? How do we determine what's critical care and what isn't? So in a series of calls at a global level, but with involving country level staff and the technical people from highly operational agencies, we talked through what this would mean in such a context. And it was through these calls that the document basically emerged and was developed. And then we had specific additional chapters that came up because of reported requests from the field. So for example, the chapter on psychological first aid, people were saying, how do we do this in this response? Is it appropriate in this response, or should we be doing other interventions as well? Particularly focusing on children and adolescents and youth, and the fact that they were out of school and they didn't have access to normal communal spaces, but also a group that's often overlooked in emergencies, which are people that are dependent upon alcohol or are using other substances for coping purposes, and ensuring that they had continued access to treatment, but also advocating for the fact that people don't start drinking or don't start using substances inappropriately as a negative way of coping because of the pandemic as well. And there's also advice on adaptation of services, for example, for survivors of SGBV as well in emergencies. The second document is the basic psychosocial skills document, and this came up really, again, through this iterative process where we were hearing from the field that, okay, psychological first aid is perhaps not the appropriate intervention or the only intervention in this pandemic because the emergency is incredibly long. The impact will be lasting for months and months. What else can we do? And it's also in recognition of the fact that essential workers are still working and have remained working throughout the pandemic. Your essential workers being your policemen, your border guards, your shopkeepers, your people collecting the rubbish, for example, in addition to the formal healthcare workers and the social care sector workers as well. And these are important staff that have kept countries running. They've kept societies functioning, even when people have had to be locked down in some context or another. So in recognition of what they're doing and the role that they're doing, and this really important key community interlocutor and their ability to navigate communities, we decided to put out this document. And that's why you'll see the format is a little bit different to the other document. It's got this wonderful graphic illustrations with examples of all the different professions and all the different descriptions of what is an essential worker. And it goes beyond psychological first aid, and that's the key thing. We're really looking at foundational, basic psychosocial skills that anybody can be equipped with and can do and can use. And it's about having a more human-to-human interaction and a more sympathetic interaction with the public in which they're coming to face with on a daily basis as well. Could you have the next slide, please, Christina? Yeah, so on this slide, we have some very famous people on this slide. You will see on the top row, we actually, the picture is from Teresa Ombalo, who I know is also on this call as well. Teresa is one of the roster members of a Dutch standby partner called RVO, the Netherlands standby partner organization that provides surge support for many humanitarian organizations. And we have, in partnership with them, developed a roster for MHPSS professionals that can be deployed in the interagency context in various emergencies. And it actually started this year. It's something that we've been working with them for a couple of years now, and it was launched in January. And we now have deployments to 7 countries, which has been quite amazing, seeing that we've also had the COVID-19 pandemic at the same time. So some have been deployed remotely and providing remote support, and some, like Teresa, was very brave. She got on the last plane into Ethiopia, was at the airport, was met at the airport and went straight into quarantine for 2 weeks, working remotely from the hotel room, and then was able to step out and do her job more broadly. So we have a number of people now deployed, as we said, to 7 contexts for a minimum 3 months, but some of the deployments are longer now, to basically support the work of these country-level MHPSS working groups. And what you can also see on the top level is examples of how the materials are being used in practice and how they're being used to inform programming work. So you can see that a role that Fami and I used to do when we could travel internationally was to do country-level support missions to support the work of these interagency groups. We're not able to do that in person now, but we're still able to do it remotely. And it's what it takes up a lot of Fami and my time, quite pleasurably. It's a nice part of the job. And you can see the examples there are from Ukraine, where Fami just recently did a training for them, and I will be doing one in the end of July. But also support to, for example, Yemen, where Fami was just before COVID-19 hit Yemen, and also support to local organizations who are providing direct services, for example, in Idlib and in Aleppo that you can see in those two pictures. The one in Idlib is running a helpline for people to be able to call in, and the second picture is also an example of home-based care and basically decentralizing mental health treatment so that it can be provided at home for people that can't travel to access healthcare in a normal clinic or facility. And the last picture is actually from International Medical Corps from South Sudan. And it's also an example, what you can see in the picture is a healthcare worker that's learning stress management techniques, particularly breathing and relaxation techniques, that's being taught by a fellow health worker. And it's an example of how we have staff care and the focus on staff well-being that's been incredibly important in this emergency as well. And Fahmi, I'll hand over to you for the last section. Thank you.
Thank you, Sarah. And colleagues, all these are really snapshots. It's impossible to provide all the work done by all the IASC partners on MHPSS. So the picture you see here, for example, is an adaptation for the IASC MHPSS messages in the briefing note, but adapted for Yemen so that it can be sent on WhatsApp, where physically the workers cannot go to provide in-person support. Second image here, the one with the newspaper and the Greek letters, is actually an innovative way of disseminating the messages in the children storybook, in essence, during the lockdown, to reach the children at their home while they were with their families back in March, when there was lockdown, in essence. And the next picture is actually My Heroes You children book, but adapted for native Indian Americans, adapted by Johns Hopkins University for Turtle Island in the USA for this population group. And the next picture with the Arabic letters is actually from the Norwegian Refugee Council in Gaza as part of their education program, a competition for children drawing to express how they acted like a hero, like it's a child in the book during COVID-19, and how they were coping. In fact, the book was adapted into an audio series of three episodes in Arabic in Gaza. And the last one, which is really difficult to see, but very important, and we all very proud with, is in fact done by a group of volunteers, Zimbabwean Blind Mothers Trust, who developed it for dissemination for other blind mothers and for other children with blindness to be able to read the story of My Hero Is You. Thank you.
Perfect. Huge thanks to Sarah and Fahmi for this eloquent intervention. And again, I really appreciated how you've relayed the critical work that's happening at the global level in terms of the formulation of policies and guidelines and practical tools, how you've adapted very quickly and have come up with innovative and creative ideas to adapt to the COVID realities of movement restrictions, and how that's all been translated to actual support to the field, whether it's in terms of surge support to the field, including remote support, given the travel restrictions, whether it's in support to the technical working groups that have been established on the ground. And I understand that many more MHPSS working groups have been established since the COVID crisis commenced. And also, again, and thank you also, of course, for highlighting the good work that has happened also through the Global Humanitarian Response Plan, and with the first time that we have actually indicated to measure the progress that we're making on the MHPSS issue. So maybe with that, I will turn to Nadia, and it's great to actually hear from both Nadia, followed by Deborah, on how all of these global initiatives and discussions are actually featuring on the ground. And specifically, for maybe starting with Nadia, more practically, can you give us a picture of the MHPS concerns faced in Afghanistan and the impact of the COVID crisis there? And more practically, how MHPSS work is being prioritized and streamlined and implemented in Afghanistan and some of the challenges you're facing and how you are addressing these challenges. I know quite a bit to cover in 5 or 7 minutes, but perhaps over to you, Nadia, and then we'll go immediately to Deborah to also give us a visual of the same issues from Nigeria before we turn to questions and answers from colleagues. Over to you, Nadia.
Yeah, thank you very much for giving me the time to discuss in relation to Afghanistan and MHPSS Working Group and update. Actually, the situation in Afghanistan is that school has been closed since 3 months and for 3 months till since 15 May. Movement have been restricted due to COVID-19. Cases are increasing as people don't consider preventative. This is underdeveloped country and people always do not consider the measures. Most people have concern about their own health and about health of their loved ones. And they also have concern about their livelihood as they are providing for their family many daily workers and laborers, and they are working in informal sectors. They are experiencing anxiety and stress. There is also a high level of discrimination and stigma towards people infected by COVID-19. Face-to-face counseling has been stopped as bit counseling and also group counseling. Community-based activities have been stopped because of risk of transmission of COVID-19. NGOs have shifted to online and remote psychosocial support, tele-psychosocial support. And awareness is being done through multimedia brochures. NGOs train their workers to support affected population. And IASC operational consideration and as well as IASC briefing note is being used to inform services changes. Staff are experiencing stress and advocacy has been done at ICT Intercluster Coordination Team meeting for staff welfare. WHO has developed information guide which was useful tool and resource for the staff to use. The IASC tools has been used is being used widely in Afghanistan as a part of MHPSS response. The document is used on training of online and hotline health workers. The document is also being used in development of IC material, messages, posters, banners for adults, children during quarantine. The document is also being used as a part of the survey and also the reports. The information from the document is also being used as on weekly updates on COVID-19 response in Afghanistan. The document is also being used as a guide for preparing indicators for HRP. The children's storybook, My Hero is You, is being used as a home-based toolkit for children during quarantine. The document is developed as a source for parents to support facilitation of MHPSS activities at home. It's also being used as a part of awareness programs. The basic psychosocial skills is widely being used by psychosocial counselors and NGOs. As a part of our response in Afghanistan, NGOs are providing tele-psychosocial support to respond to the situation. MHPSS questions are included in whole of Afghanistan assessment. MHPSS specific indicators are included in HRP. The indicators are currently under protection. And then Afghanistan services are adapted as remote programming and modalities, hotline, helpline to the situation. Mental Health Department Directorate has developed policy brief for COVID-19. WHO developed information guide for staff care. How can staff manage their stress? WHO also developed a platform for population for assessment of their mental health and also how to access psychosocial support in the country. MHPSS Working Group is regularly coordinating and participating in inter-cluster coordination meetings. Thanks. If there is any question, I'm here to respond. This was the update about response of COVID-19 and COVID-19 situation in Afghanistan. Thank you.
Brilliant. Many thanks again, Nadia, for giving us a clear picture of the situation in Afghanistan and some of the practical measures that are being taken. But again, I hear you loud and clear in terms of concerns with the provision of mental health and psychosocial support in light of the movement restrictions. But I also hear, of course, concerns that you flagged around discrimination and stigmatization towards those affected by the virus, and all of the concerns around anxiety and stress due to loss of job or loss of income, which I suspect is also going to be exacerbated as we move forward and as the number of people being affected in Afghanistan and the region is projected to increase. But also a positive story, again, in terms of how you're using some of the IASC policies and guidelines on the ground, and the good news with regards to, again, the indicator on MHPSS and the HRP. That is, again, an important improvement and progress and a movement in the right direction with these critical planning documents and processes led by the UN. I may come back to you again, or maybe the response could potentially feature in Deborah's interventions around, in addition, of course, to engaging with the ICCG, the Intercluster Coordination Group on the ground, would be fantastic to also hear how we are engaging with the government on the issue of MHPSS. So maybe with that, I'll turn to Deborah, and again, taking the opportunity to encourage colleagues, please do use the chat box if you have any questions, comments, advice. Please do share it in the chat box, and my colleague Christina is kindly consolidating all of these questions directed to the panel. So over to you, please, Deborah.
Thank you very much, Melvat, and really appreciate all this opportunity to share from the experiences from Northeast Nigeria. And greetings to all from Maiduguri. Prior to share what Nadia already explained on about the situation in the Afghanistan, prior to share about the mental health and psychosocial concern and the impact of COVID-19 pandemic in Nigeria, in particular in the Northeast, kindly allow me to share briefly on the coordination structure that we have in the Northeast within the MHPSS Working Group. So the working group is co-chaired by IOM together with the State Ministry of Health, and the relevant MHPSS partner and stakeholders are providing the intervention in Borno, Adamawa, and Yobe states. So we are supporting the government of Nigeria through the SMOH and other relevant ministry, and coordinating the activities with other sectors such as health, child protection, GBV, camp coordination, camp management, education, and livelihoods. And currently, there are 49 MHPSS partners from national NGOs, international NGOs, RCRC movement, UN agency, and government institution. And the number of national NGOs providing mental health and psychosocial support is growing since 2019. So when we share about the concern faced in Nigeria, Christina, maybe you can move to the next slide. So it is not separate from the context of humanitarian crisis that continue to cause sufferings for millions of Nigerians. So a total of 7.9 million people in need of life-saving aids, with women and children constitute of 81% of the overall crisis population and 87% of the new displacement. This is based on the Humanitarian Response Plan in 2020. So in a complex setting like Northeast Nigeria, with more than 140 IDP camp setting sites and another urban area, so we face issues of congested camps, lack of access to potable water, sanitation and hygiene, increase of fire outbreak, flooding, food insecurity, malnutrition, limited access to the health facility, multiple disease outbreaks. So the COVID-19 is not the first outbreak. We have Lassa fever before, we have measles and other outbreaks, and increase of sexual violence and abuse. So it has a major impacts of the overall living standard, physical and psychological well-being, and the capacity for resilience and having positive coping mechanisms among the IDPs, returnees, and host communities. So the next one on the slide is with already existing challenging conditions. So the COVID-19 is increasing the psychological distress among the affected population. There are anxiety, fear, confusion, and also frustrations. They're also worried about their own and the health of their family members, like Dr. Fahmi already mentioning earlier. There's also like a worried about the risk of contracting or transmitting COVID-19. Also cumulative of family tension, intimate partner violence or gender-based violence, and also experience a period of lockdown scenario that we had before. So that's like one of the impact to the increase of the violence, and also worried for not having access to food with issues of economic hardship or lack of livelihood, limited access to services, including mental health and psychosocial support. And the people are worried to visit the healthcare facility due to the high level of stigmatization. So then what is some of the challenges that we are facing and how we deal with this? To answer that kind of like challenges, I might bring into the reality that we are facing here. So we are dealing with the community that many of them are not believe that the COVID-19 is existed. Or some mention that this is like a white people disease. And there's issue with the mistrust the government, that they're seeing this as a way of government to impose the regulation and taking more advantage from the poor people, and many more of misinformation. Nadia mentioning about the stigmatization, it's also happened in Africa, and I mentioned about in Nigeria particularly. There's a high level of stigmatization. There's a label of Corona house given to a house with any family members with COVID-19 positive. So there's also like we experienced about the movement restriction and lockdown scenario before being taken by the government. So it created like major consequences on the delivery or provision of MHPSS, with an understanding of number of psychological distress and other related mental health conditions. The use of substance or local drugs was like high, and also limited access to the clinical care for people with pre-existing and mental health conditions. So Christina, maybe you can just go into the next slide. So it acknowledged that the standard of COVID-19 prevention measure may be more challenging, and in some cases, even if impossible to implement in the complex setting like Nigeria, to like hand washing, maintaining physical distancing or self-isolation. So the current MHPSS approach is evolving and adapting to the needs of population, and the program is prioritizing on the remote support, remote counseling services, peer-to-peer support for people living in the same household, although the utmost priority is the safety and well-being of the staff or volunteer while carrying out the intervention that might require an urgent home visit or face-to-face contact, with ensuring that the availability of PPE and they need to wear a face mask, maintaining physical distancing, and following hygiene measures. So from us in the Northeast, with those experiences, lockdown scenario, and then how it's important to engage directly with the community. So we consider that this is a really a momentum to see the essential of localization strategy or building a capacity of local organizations. So when lockdown is applied, no direct access to the affected population, and we cannot go to the IDP camps or host community. The MHPSS partner and humanitarian actors are working closely with the locally recruited volunteers to continue their activities. This is also including on the community awareness, sensitization in the hard-to-reach area, area or the locations in the Far East and the central of the Borno and in IDP camps. So as well as to provide basic psychosocial support to the community. Link to the tools, so maybe the next one, the last slide from my end. So link to the tools that were developed by the IASC Reference Groups on MHPSS in emergency setting, and what Dr. Fahmi and Sarah have really shared brilliantly earlier. So the interim briefing note was published in a very critical time when the MHPSS partner in the country level need a guide of what to do. There's like a confusion in the beginning and how we adapt our regular program and the activities, and also with the condition of changing regulation from the state government. So the tools are very useful as a reference and also providing the ideas on what to prioritize. The MHPSS Working Group contribute the information using the tools to the Borno State Ministry of Health COVID-19 Preparedness and Response Plan in March 2020. So the interim was out during those periods. So we are using that as our reference at that time. and the COVID-19 preparedness and response priority for the ongoing humanitarian situation in Northeast Nigeria. This is developed by the health sector and their communication with the MHPSS Working Group to contribute for some inputs, and also to the multi-sectoral response strategy of COVID-19 in Northeast Nigeria. MHPSS partner also use the guidelines, the tools to adjust the project proposal and the MHPSS activity. So at the national level, the mental health and psychosocial support is included in the chapter of management of complication of COVID-19 in the National Interim Guidelines for Clinical Management of COVID-19 in version 3, released in June 2020. It was not there during the first and during the second version of the guidelines. So after the third one, they put the paragraph of the MHPSS, which is really, really good and being like acknowledged by even the government at the national level. So the other tools that I would like to share then also relevant to the Northeast Nigeria is the My Hero Is You, the story of children on COVID-19 that was translated into local languages, Hausa, Kanuri, and Suara. This is the three of primary languages on the language based on the language mapping from the Translator Without Borders. So we are planning to have more translation on the IASC guidelines on basic psychosocial support, a guide for COVID-19 response. This is just to really expand our responses to all the community and volunteers and other partners. I think this is what I can share for now. Over to you, Melva. Thank you so much.
Many thanks again, Deborah, and absolutely great to hear also your interventions around the engagement of the Mental Health and Psychosocial Support Working Group with the government and in support of the government. Again, the visual with regard to also the number of local NGOs and the increasing number of local NGOs that are engaging in the MHPSS working group, and we currently have 49, and I know that they are on the increase. Thanks also for giving us a clear visual of some of the limitations and the challenges in operating in low resource settings, especially in camps and camp-like settings. Again, I was also intrigued by the comment by Leila in the chat box from UNHCR, where she spoke of, again, the issue of substance abuse and the increased use of alcohol in the north of Brazil in response to the Venezuela crisis. So again, that gives a sense of the multifaceted, again, nature. Every context, there are different ways in which people deal with mental health and psychosocial concerns. So, and again, very revealing as well, you know, Deborah, again, you've highlighted a particular issue around, you know, especially culturally as well, you know, the denial that the virus does exist, lack of trust to, you know, in certain contexts of local authorities. And so how do we deal and how do we operate in similar contexts? But I was also happy to hear, and again, in Fahmi's interventions, that there was a lot in the development of the guidance looking at how we responded to the Ebola crisis, how we responded to the H1N1 and other, you know, similar pandemics, to inform the guidelines and the tools that have been developed. And I know that there's a lot of work and interaction with the working groups on the ground to make sure that we benefit from previous experiences as much as possible. So maybe with that, we'll just turn. I see that there are a number of questions that have come in, and I can see a question, and maybe I'll direct it to Fahmi, and it's from George Obiro. And the question is on how will the COVID-19 pandemic present an opportunity to highlight the importance of MHPSS in humanitarian response, especially in light of the high degree of stigma that needs to be addressed to have an effective COVID-19 response. So maybe I'll direct this question to Fahmi, and then I'll turn perhaps next to Nadia. And there's a question from a colleague from ADRA. Do we have policies in place to implement MHPSS at the institutional level? Do we have policies in place to implement MHPSS at the institutional level? And I'll direct this question to Nadia. So perhaps, Fahmi, maybe you can take the first question, and then I'll ask more questions as they come in. Over to you.
Thank you, and George, thank you for the excellent question. The answer is always during during emergencies, we see there is an opportunity to scale up mental health and psychosocial support. It's an opportunity. It's an unfortunate opportunity that we do not do it before emergencies and invest in this area of work. But it is a great opportunity when emergencies happen that policymakers, governments, actors, all are interested in MHPSS. All that's right, because it's needed. We have many examples in humanitarian settings where MHPSS came on the agenda only when there is a large conflict or a large emergency. Take, for example, the Syrian crisis. Before 2011, mental health services were only available in Damascus and Aleppo. Today in 2020, mental health services in Syria during the conflict, or maybe because of the conflict, are available by many actors in community-based settings, in family centers, in educational facilities, in more than 11 cities, and starting from a baseline of 2 cities before the conflict. Same happened in Philippines before Typhoon Haiyan. Same happened in countries affected by the Ebola crisis. So the opportunity is now to put MHPSS on the agenda and benefit during the Building Back Better in shifting from the system before the emergency, which is clearly dysfunctional, many countries relying mainly on institution, into community-based and evidence-based services adapted to local context. And not only we need to do Building Back Better, we need to remember that in all countries we need to do Building Better before, getting ready before the next crisis happens. Thank you.
Thank you, Fahmi. Over to you, Nadia, please.
Yes, thank you for the question. Actually, it's a very relevant one. The mental health policy brief covers this institutional care for institutional people in COVID-19 and psychosocial support for people in institution. Actually, the information is extracted from IASC operational consideration and IASC briefing note for the people in the institution. So the policy brief covers those parts. Thank you. Afghanistan policy brief developed by Mental Health Department Directorate.
Excellent. Thank you so much, Nadia. And maybe over to Fahmi. I can see that you may have additional points to augment also in the response to this question. Over to you.
No, I think Nadia responded clearly, and indeed institutions are reflected in many of the guidance we just shared, and I shared the link of this guidance here using the chat function. And if the colleague from ADRA means that at institutional level by organization level rather than actual physical institution, I want to say that all the 58 members of the IASC Reference Group endorse at organizational level the MHPSS guidelines of the IASC and implement it. And one of the key things in MHPSS is that it's a cross-cutting issue, and institutions adopting the IASC MHPSS guidelines commit also to apply it as a cross-cutting issue of relevance within different sectors, and even also within the same sector. I mean, for example, take WHO as a health sector. MHPSS is cross-cutting within health itself, within the pillars of COVID itself. MHPSS is cross-cutting of relevance to clinical management, to risk communication, to partners coordination, and logistics and support through duty of care. So MHPSS is cross-cutting across and within sectors in different institutions, and that's what we have in the IASC guidelines.
Great. Many thanks, Fahmi. And maybe with that, we'll turn. There are a couple of questions that have come in. First from Josephine, who's with the UNHCR's Regional Bureau in Nairobi, and a critical point that she's raised around engaging the youth in addressing some of these myths on COVID-19. What can, perhaps Deborah, maybe you can come in terms of what we are doing specifically in terms of targeting the youth and the young people during in response to this crisis. So that's a question directed to Deborah. And maybe after that, a question directed to Sarah on the procedures, a question coming from ADRA, the procedures to join the global MHPSS roster. to respond. So maybe we'll take these two questions, and I have a few more coming in as well. So over to you first, Deborah, please.
Yes, thank you very much for the questions from Nairobi. So that's totally true, because this is what also we experience in the Northeast Nigeria. We observe that, especially with the youth, with the level, I think the current situation that there's already a poverty, there's already like lack or not balanced education opportunities. There is no much option for the job within the Northeast, and especially with adding with the crisis and now with the COVID-19 pandemic. So the engagement with the youth is become like really important. It was also delivered by the MHPSS partners. Not many, because sometimes they focus only for the children and just forgetting about the adolescence part on the transition, which is like, this is like the most critical stages for any individuals can engage with drugs or maybe with substance abuse. So in terms of the partners, also in coordination with the camp coordination and camp management, in any decision situation, in any intervention that we want to do, we always engage with the youth or the youth leader. This is already like being in the structure within the community. And also we are using the influencer, we are using more like a powerful individuals that can share messages to the youth. We are giving them an opportunity to go into like an informal education, giving more to the skill acquisitions. So those activities that we are trying to really engage with the youth. It's not like perfect, it's not like really a one-time intervention that we can say is successful, but this is like a really working progress. We identify, we acknowledge the situation, and partners was really willing to do and then really support and do the intervention. I think this is what I can share from my end. And over to you, Melva. Thank you.
Hello. Thank you, Deborah. And I'll actually ask the last question because I know we're on the hour. And hello. Colleagues can please put their phones on mute. That would be really greatly appreciated. Maybe the last question, and maybe I'll direct it to Fahmi again. A question from Mavin or Kathy from UNHCR in South Sudan, and I guess it's also in reaction to the very sobering point that you've mentioned around only having 4 mental health clinics in South Sudan. So knowing the limited number of mental health specialists in areas like South Sudan and limited investments in MHPSS that was done prior to COVID, what else can we do more to address and respond to MHPSS, knowing that there are more vulnerable people in need of mental health and psychosocial support? So I guess this is really goes to the crux of the matter. It's an important issue. The infrastructure is not strong enough, and that's been the case before the COVID. What can we do given these obvious limitations? Over to you, Fahmi, and we will conclude with this last question.
Mervat, thank you, and thank you, Mavin Jek, for this very good question. The situation in South Sudan is quite remarkable when it comes to the deficiency, the huge deficiency and limited availability of mental health human resources and the limited investment in this area. As I said, it's 4 specialized professionals for a country of 12 million on a rate of 1 for every 4 million, and 1 person needs service for every 5, but we have 1 person to provide the service for every 4 million. And the service is mainly centralized only in Juba. But the situation is not unique. It happened before. There were many other countries who were in the same situation. In Sri Lanka, for example, covering millions of people after the tsunami and after years of civil war, and millions of people having 1 mental health professional. So what did Sri Lanka do at that time? Group of MHPSS actors committed and came together with a group of local champions. So you need group of agencies committed, and you need local champions. You need funds. You need donors who would support your scale-up plan. And you need a comprehensive plan, multi-year plan. We cannot rely when there is very limited human resource available on a 6 months or a 1-year plan. There are things we can do on acute and short-term basis, but countries like Sri Lanka scaled up the service after the tsunami. It took them at least 8-year in a comprehensive plan. They start to show pilots, they start to show success. Gradually, more areas were covered by service. It was success story there, but it was a multi-year plan. They had funding, but every agency involved would take a role, and they applied what we know as task sharing. They built the capacity of health workers and also psychosocial and social workers to do what the specialist can do, supervised and mentored by specialized professionals, and created curriculum for this scale-up plan. So the answer is agencies coming together, funds becoming available, local champions, scale-up plan with task sharing in the core. And I think partners were able to make huge progress in South Sudan, and the potential is now to do similar work in South Sudan. Thank you.
Thank you, Fahmi. And apologies, because I know there was one question directed to Sarah that I failed to create the space for Sarah to come in. So maybe, Sarah, if you can come, and I know you've provided the response in the chat box, but if you can just perhaps come in to respond to this question so that colleagues can hear you, and also maybe just deliver your final remarks or reflections so that we conclude this session today. So over to you, Sarah, please.
Thank you, Mervat. So in response, the question I responded to in the chat function was the one about how can I join or learn more about the global roster for MHPSS. The roster is run by the Dutch standby partner, who's called RVO. And I have put the link to the website where you can learn more about the roster and the standby partner more generally, how they manage it, what qualifications or professional background you need, the types of deployment and how to apply. And I've also put down the email address of the person that you can contact at the Dutch standby partner. Her name is Sylvie Hoekman. Who you can ask if you have questions, more specific questions to learn about the roster. Fahmi and I in the co-chair role, we technically support that roster in the terms of we help with the deployments, we help with technically supporting people when they're deployed, but we don't manage it. That management is done by the Dutch standby partner. And I should also say that is also supported by the Kingdom of the Netherlands, as well as the back funding partner. And then I think with my last remark, I would say that there's been a lot of very good work, I think, done within the COVID-19 pandemic response, and a lot of visibility is being given at the global level. I think we're beginning to see much more traction and kind of respect for the area of MHPSS at a global level within the humanitarian response. I would really like to see that positive energy and discussions happening at the global level to also happen at the country level. And that also means we need to have funding at the country level. We need to have these discussions much more at country level. Because that's where the response is happening in this emergency. It's a highly localized emergency, which means we are completely dependent upon local actors and local response, and we need to give them the voice and the power in this emergency. So I would really like to encourage actors and partners to also focus and give visibility to country level initiatives and activities. Thank you, Madam.
Great, perfect, Sarah. Maybe actually I'll turn to Nadia, then Deborah, and then we'll conclude with Fahmi. Over to you, Nadia, please. Final takeaways, remarks, advice before we conclude.
Yeah, so takeaways from the meeting that MHPSS concerns should be considered, and we should coordinate for the MHPs to strengthen MHPSS in the country to meet the need of people in Afghanistan, and then through advocacy, through inter-cluster coordination teams and other coordination platforms available in the country to at least meet basic needs of MHPSS, providing MHPSS on-time support for the population.
Great, thank you, Nadia. Thanks a lot for your final remarks. And over to Deborah, please.
Yes. Thank you very much. What I can share from my end, being in Nigeria and not leave the country since the onset of the COVID-19. So we are witnessing the anxious, the worriness, the fear when the first COVID-19 case was confirmed in Borno State, the epicenter of Nigeria's conflict-affected states. So with the experiences, this kind of situation, realizing that the three key important elements of preparedness, coordination, and localizations. So the COVID-19 is exposed and increased the vulnerabilities of the community that have been affected by the conflict, insurgency, and protected crisis. So we need to strengthen the preparedness, have a proper coordination, and when the world was stopped, when the lockdown was imposed, and no direct access to the affected population, we can only rely on the national, the locals, and the community volunteers, including to deliver the basic mental health and psychosocial support intervention to support them, to enhance their resilience and their self-efficacy of this affected population or affected community to be able to cope with the current adversity. Thank you very much, and over to you.
Thank you, Deborah. Thank you for the nice closing remarks. And maybe with that, over to Fahmi.
Mervat, first I want to thank you. This opportunity and this briefing show how the IASC is prioritizing MHPSS. We thank you very much on behalf of all the MHPSS community and the humanitarian response, for which MHPSS is an integral component. I want to remind all colleagues that MHPSS is an essential and integral component of any humanitarian response. It's a basic need. It's not a luxury. It's not the function of MHPSS actors only. It is the function of health protection, child protection, GBVOR, nutrition actors, WASH actors, camp management and coordination. All sectors and all clusters have the mandate to include MHPSS in all their work, just like how they include other cross-cutting areas such as gender and such as disability. MHPSS is also a cross-cutting area and recognized as such in all humanitarian actions. And finally, I don't think there can be a COVID response without MHPSS. MHPSS is an integral component of any COVID plan, preparedness, and response. Thank you.
Excellent. Great closing remarks as well, Fahmi. And it's actually the thanks is to you, to Sarah and Nadia and Deborah, really for a fantastic session, but also more importantly, the brilliant work that you're doing on the ground. Again, this is a very important topic, but of course, the challenges are quite huge, especially around the capacity aspect. I'm glad to hear that there is some progress. We're moving in the right direction, but there's a lot more to do in terms of raising further awareness with regards to this basic need, as you pointed out, Fahmi, around, again, the need for more resources, around the need to make sure that, again, as much as the attention at the global level, the policies are being formulated, but at the same level of attention is also given at the field level where the rubber really hits the road. So again, really huge thanks to our four panelists. This won't be the last time that you're going to see MHPSS featuring in an IASC briefing. Again, we're committed to make sure that this features regularly. But at the same time, maybe I'll just take advantage of having colleagues online to announce that the next IASC briefing will be taking place on the 8th of July, and it will be looking at the impact of COVID-19 on women and girls. The impact of COVID-19 on women and girls on the 8th of July at 3 p.m. Geneva time. And I very much look forward to having most of the colleagues online today joining us then. So thank you again, once again, and wishing you all good health and a good day. Thank you.